Dear Chairman, ladies and gentlemen, good afternoon. My name is庆莉 from Peking Union Medical College Hospital. I'm so honored to be here today. Today I would like to share with you the current research progress and our experience on the preoperative contrast enhancement ultrasound for sentinel lymph node in breast cancers. Breast cancer is the most common cancer diagnosis in Chinese women. The rapid increase in the incidence as well as the large population in China have a great influence to the global cancer burden. So it has become one of the most important health issues in China, which has drawn great attention from the government as well as the public. The definition of sentinel lymph node, or SLN, is the first lymph node draining the primary cancer. Thus, it could represent entire lymph node basin, a centers of entire lymph node basin. Influenced by the current concept, lymph node standards evaluation in breast cancer change from the accelerated dissection into sentinel lymph node biopsy. And sentinel lymph node biopsy is considered as the gold standard for accelerated staging in early breast cancers. So now let's look at how it happened. In 2003, a study showed that patients with negative findings from the sentinel lymph node biopsy who did not undergo complete accelerated dissection have had an improved quality of life without ill effect on the eventual disease outcome compared to those who underwent the complete accelerated dissection. So 2 years later, the expert panel from American Society of Clinical Oncology published their guidelines recommending sentinel lymph node as the initial alternative to accelerated lymph node dissection in patients with early stage breast cancers, and advocating only women with positive findings in the sentinel lymph node will undergo the complete dissections. In 2010, the result from the famous Z0011 showed that the complete accelerated dissection offers no additional benefit in women with stage T1 or T2 with only one or two positive sentinel lymph, only one or two positive lymph node. So it further changed the clinical paradigm for breast cancer treatment. In 2017, they published the 10 years follow-up result, and it showed that patients treated with sentinel lymph node dissection alone was non-inferior to overall survival rate compared with those patients treated with accelerated lymph node dissection. So all in once, less is more is the concept for early stage breast cancer treatment. Lymphatic mapping techniques, including radioisotopy, blood dyes, or combines, averagely 95% of the patients have had successfully mapped sentinel lymph nodes with dual localization method. Nevertheless, radioisotopies are expensive and difficult to manage. Blood dyes are cheap and easy to use, but constitute a more invasive method and it need great care in fetting lymphatic channels. So there is now a strong need to find alternative method to achieve reliable accelerated staging method, which is less invasive, not dependent on radioisotopies. By intradermal injection, microbubbles can be seen in the lymphatic vessels, and it is safe and no pollution. So CUS is a promising method in the preoperative sentinel lymph node mapping. This is how we work in the sentinel lymph node CEUS. Microbubbles was injected in the periola area, but tracing along the course of the enhanced lymphatic channels, the first enhanced node can be seen very clearly, and it was deemed as the sentinel lymph node. This is the research focus on the CEUS evaluation of the sentinel lymph node. It could be divided into 3 parts. The first one is identification of a lymph node. After that, CEUS could guide further biopsy. And the recent studies demonstrated the enhancement pattern could be helpful for the diagnosis of lymph node involvement evaluation. The sentinel lymph node identification rate by contrast enhancement ultrasound was above 90%, which is compared to that of the blue dyes, radioisotopian, and fluorescence. And many studies has also confirmed that sentinel lymph node located by the CEUS is the same lymph node during the surgery, with the same lymph node with the blue dyes and fluorescence. In these studies, the sentinel lymph node were clearly visualized and successfully biopsied in 96% of the patients. The prevalence of metastasis is only 27%. From this picture, we can see very clearly that this is afferent lymph node vessels entering the sentinel lymph node, and it could be further guide the biopsy. This is our result. The enhancement was divided into 3 types: the homogeneous patterns, which means benign, heterogeneous enhancement, and a non-enhancement. Both of them are considered as the malignant or metastasis. This is our result. If we evaluate an enhancement pattern with metastasis or not, the diagnostic value was achieved a very high sensitivity, and a median rate of the specificity is only 52%. If we consider the enhancement pattern with the sentinel lymph node tumor burden, we found that the specificity is even lower to only 34%. But if we look carefully, we can find a very interesting phenomenon. Most of the heterogeneous enhancement pattern represent the low tumor burden. It is very interesting. It implies we could further divide this pattern into more subcategories to improve the specificity in the future studies. When non-enhancement or the heterogeneous enhancement combined with the positive result of ultrasound-guided biopsy, we can achieve a very high, we can improve the specificity to 100%. If we consider the tumor burden, with low tumor burden and high tumor burden, the sensitivity is increased, which also keep a very high specificity. So now we know in breast cancer patients with normal B-mode ultrasound accelerated lymph node, CEUS-guided sentinel lymph node identification has been confirmed as a reproducible technique. It could identify 50% of nodule metastasis with ultrasound-guided biopsy. An enhancement pattern of sentinel lymph node help to differentiate metastasis or not. Nevertheless, there are few data from the prospective study if this above preoperative CUS could further improve this axillary lymph node management in the real world. In our studies, we found the homogeneous enhancement had a very high negative prediction value and high observer agreement, which means we may rule out metastasis if the patient has such homogeneous enhancement lymph node. While in the inhomogeneous enhancement demonstrated a considerable overlap between the metastasis or not. Some authors thought it was significantly associated with the tumor infiltration, but others suggest that it may related to the nodule structures or the lymphatic dynamic changes, which is also very interesting things to study in the future. While the non-enhancement is a pattern highly suggestive of metastasis. The possible mechanism was speculated as maybe the tumor cells proliferated in the sentinel lymph node and infiltrated almost the entire lymph node, or the tumor cells infiltrated part of the sentinel lymph node but obstructed the main lymphatic channels, causing the sentinel lymph node to present non-enhancement. The enhancement pattern could be helpful for characteristic of nodule burdens, which is very interested in the right now surgical management. A homogeneous enhancement, just like this in the first cases of our slides, it may be ideally suitable for mid axillary lymph node dissection, while the no enhancement pattern implies a very high nodule burdens, which means patients would have a very high risk to receive axillary lymph node. But we would like to emphasize that in this scenario, the detection of precise number of metastasis axillary node should be evaluated histopathologically. No diagnostic imaging method, including ultrasound, is suitable for the entity of the node involvement. This is a very typical inhomogeneous enhancement. So, in conclusion, CUS is a feasible approach for sentinel lymph node identification and characterization. The enhancement pattern on CUS can be helpful to recognize the metastasis of sentinel lymph node and provide very important information for the axillary management. Now let's move on the operation demonstration. Let's look at these videos. Before the operation, we can do the ultrasound, breast ultrasound first, and the lymph node status by conventional ultrasound. This is the microbubble preparation. choose the same part of same injection site as the blue dyes or the isotopia injection parts, also the papillary area. We'll make some machine judgment to suit the techniques. We will find the lymphatic channels, just like this, like our very bright channels into the axillary part, and this is multiple lymphatic channels enter the same node. Will mark the sentinel lymph node and also the lymphatic channels on the skin of the patients, which make a very good direction for the surgery. Okay, that's it. That's all I want to say in the presentation, and now let's move on the Q&A section. Thank you. Thank you.
Thanks, Professor Zhu, for giving us an excellent presentation about the USC breast and lymph node. Professor Zhu is online.
Hi, everyone. I'm so glad to attend Eurosong School online and say hello to everyone from Beijing. I'm sure you're enjoying the course very much. Today, I have two cases to share with you. The first one is a female patient, 52 years old. The left, this is the top one. The top is the breast lesion, which can be found on the left breast, and biopsy-proved invasive ductal carcinoma. And the bottom line, we can see the CUS. Please click the movie for us, please. 点一下那个动态的图像可以吗？ Okay, thank you. So this is the CUS movie. We can see the lymphatic channel enter two lymphatic channel enter the same lymph node, and the lymph node demonstrated as a homogeneous enhancement. We can see the dual model with contrast enhancement pictures and the B mode ultrasound at the same time. So my question is, what's your answer? Is metastasis or not? You can scan the maybe I can next. Can I see the result from the audience? It's okay. I will tell you I think most of you can say this is a homogeneous enhancement and turn out to be uninvolved lymph node. Okay, I'm happy to see the result. Okay, next please. The next case is a 57-year-old woman with biopsy-proved invasive ductal carcinoma. Let's see the movie first. The lymphatic channel is very clearly demonstrated. But at the end of the lymphatic channels, we found nothing, right? By dual model, we can see there is a lymph node with thinking cortex. So we can see the lymph node is non-enhancement. That is no enhancement at all. So what's your answer? is metastasis or not? Can we see the answers from audience? Okay, I think most of you would think it is metastasis lymph node, right? Yes, non-enhancement is a very specific features to diagnose metastasis lymph node in the breast cancer. So that's all I want to say today. Next, please. I want to thank you for the president, for the chairman, and all the audience today, and I hope you all stay healthy.